And thank you, everybody, for joining our monthly session here. This is somewhat what we call our telementoring program. We have 3 versions of this each month. This one is focused on community healthcare workers, but basically everybody's invited. So if you have some colleagues that would potentially benefit from this, it would be great. This series that we're doing in 2022 is related to geriatric syndromes, but they still revolve around this main concept that we keep promoting, which is the geriatric 4 M's. And to a certain extent, I add the 5th M, which is medical complexity. So I just have that disclaimer there that we like to explain geriatrics in terms of the 4 M's, but then also to talk about some of the more difficult issues that we need to encounter and deal with. Okay, next slide, please. So the objectives today are to understand the incidence and the morbidity of depressive disorders. We want to look at the diagnostic criterion for, particularly for depression, talk a little bit about mania. We'll go over some of the treatment options, and then also discuss the action and the side effects of these medications. Next slide, please. So we'll cover these topics of the epidemiology, what the distribution is, who it affects, what the clinical presentation is, always remembering that there are atypical presentations in older adults compared to younger populations. And then we'll talk about trying to seal the diagnosis and what the treatment is. So we have a case study here that I would like you to reflect on. It's a 67-year-old female. She has hypertension, diabetes, hyperlipidemia, coronary artery disease. She was brought to the emergency room by her daughter for nausea, confusion, fatigue, and loss of appetite for 3 days. The patient felt sad since her sister passed away 6 weeks ago and was prescribed the SSRI called fluoxetine by her doctor. This occurred 2 weeks earlier from the emergency room visit. And when she was examined, she was found to be lethargic. She was only oriented to place and person, had what we would call psychomotor slowing or slow speech, and a laboratory test amongst many revealed that there was a serum sodium level of 124 milliequivalents, and that's considered low. Okay, so she had what's called hyponatremia. So in reflecting on this, the question is, was the SSRI that was prescribed 6 weeks ago a good idea? So if you have an opportunity to put into the chat box, yes or no, or don't know, maybe, go ahead and just go ahead and put your answer in there.
And whenever you do chat, make it to everyone so everyone can see. So no, someone says no. All knows.
Okay, that's great. Thank you for those answers. I think we're somewhat getting a trend here towards no with maybe a question mark, maybe, which is good, because untreated depression has a significant morbidity and mortality. So, you can always challenge the question of using the SSRI, but as we will see, what may have been some other alternatives. So thank you for those responses, and particularly for the brave soul that put in possibly. I didn't see anybody put in yes, but anyway, so let's go to the next slide. So in this case, the patient may not necessarily have depression, she has grief. And so we have to distinguish between grief and depression and what's amenable to medication. So clearly her low sodium, called hyponatremia, was induced by the SSRI fluoxetine. And this is common, it occurs in about 10 to 15% of patients. And so if older patients, so if you're a prescriber, this is something that you need to think about if somebody is getting an SSRI for the first time. It's always helpful to get a blood test to check their sodium a couple of weeks later. So the point here is that grief can persist for quite a while, but complicated grief, which is different than, regular grief, I guess. I don't know if there's a word to describe it. And complicated grief will have vegetative symptoms and will last for months after a very clear event, as opposed to saying somebody that's just, grieving over, loss of money, for example. That probably, it's usually personal relationships, although I suppose you could have complicated grief for possibly, for loss of a pet, for example. I don't know if you've ever watched the public TV series, All Things Great and Small. They really go through that whole emotional attachment of people with their animals. So complicated grief can be associated with more than one etiology, I guess you can say. Next slide, please. Okay, we have another case presentation just as an icebreaker here. I have an 82-year-old female who comes to the geriatric clinic. 4 months ago, she was tearful and sad, demonstrated loss of appetite and interest in activities. Also described sleep problems. Her son recently moved in with her after he lost his job and got divorced. There's no psychotic symptoms or suicidal ideation. So in other words, she's not hallucinating, she's not seeing things and so forth. She has a history of depression. She also has diabetes, high blood pressure, coronary artery disease, and osteoarthritis. And there's no history of any suicidal attempts or any psychiatric hospitalizations. Next slide, please. So her medications include the diabetes medicine metformin. She's on a thyroid medicine, levothyroxine, blood pressure medicine, hydrochlorothiazide, and metoprolol, Ducosate, and she's on Motrin, ibuprofen as needed for her osteoarthritis. So she had trials of sertraline and venlafaxine that were initiated 4 months ago, but they weren't tolerated too well. She had GI upset. And a lot of times you get diarrhea with these medications. And so mirtazapine was started as a different SSRI, depression, antidepressant medicine. And it was slowly titrated from 15 milligrams to 45 milligrams. Her mood is better. She's got better sleep hygiene and appetite. She cries less. But she still spends most of her time in bed and remains uninterested in usual activities. She is troubled by adverse effects of the medication, which now she says are constipation and weight gain. And the laboratory tests that were obtained in the lab show that her hemoglobin A1C is a tad high at 8%. That's borderline acceptable. You'd prefer something closer to 7%, but 8% is good. In an older person. And then glomerular filtration rate is 35 millimeters per minute. So that's considered a chronic kidney disease. So she has a low kidney function. Her thyroid function was normal. Next slide, please. So here's a question for you. Which of the following treatment options should be considered next? So discontinue the SSRI called mirtazapine and start a tricyclic medication called nortriptyline. Initiate cognitive behavioral therapy. Add an antipsychotic called aripiprazole. Add nortriptyline and not discontinue the mirtazapine. And then finally, to do unipolar ECT or electroconvulsive therapy. So Karen jumped right in there and said B. Anybody else want to take a stab at this one and commit to?
Brenda says B.
B, yeah, good. All right.
Another B.
All right, we're getting a trend here, so that's good. Yeah. Okay, yeah, well, thank you for thinking about that. So we can have the next slide. So B would be the most correct answer. So it turns out that for depression treatment, actually the first line of therapy could very well be cognitive behavioral therapy, depending upon how they score on one of the standardized tests that we use, which is called the PHQ-9. And so if they score like in a 5 to 7 range, I believe is one of the preferences or interventions is for cognitive behavioral therapy. It's very, very, very effective. In this case, in this particular case study, we're using or suggesting cognitive behavioral therapy before we start adding other medications, right? And yeah, I would just, I had an extra answer in there that didn't exist in the previous one, but anyways, I just noticed that. Yeah, so good response. Thank you. Next slide, please. Okay, so here's a question just in general. Do older adults with depressive symptoms have longer lengths of stay and 30-day bounce backs to hospitalized patients compared to non-depressed elderly? So here you can just, again, venture A or B, true or false. Great. So we are getting some responses here. So it seems as if the trend here is towards that you would think that depressed patients have more use of hospital length of stay. And it turns out, the next slide, that is not true. So kind of, surprising to me too when I went through this. A study quite a while ago found that the length of stay was about the same regardless of whether you're depressed or not in the older adult population. Now, if you answered true to that question, that would be the correct answer for a middle-aged population. So, people that are between the ages of 40 and 64 years of age, then they have longer lengths of stay and it's more complicated hospitalization rates. But for some reason in older adults, not so much. Okay, next slide, please. So the characterization of hospitalized depressed elderly, as you can see here, in the orange bar are the depressed individuals, and the red are the non-depressed, right? So you can see that I've circled their falls as being a big issue. And you might think, well, why is that? Is it their low mood or sedentariness? Or is it that maybe they're on SSRIs? And so all of those would be true, because it turns out that SSRIs, these antidepressant medications, increase the fall risk by at least 1.5 times. And I've not seen any studies that have shown whether you have more than one antidepressant medicine, whether that doubles your risk for falls, but I can only imagine that might be the case. Okay, so next slide, please. So the dose response on rehospitalization, in terms of what I call the dose response of depression, and this is based upon the score of their PHQ-9. So the higher the score on the PHQ-9, the more depressive symptoms they have. And so you can see that there is a trend in terms of the severity of the depression for causing more rehospitalization. So on average, going back to that previous slide, the older adults don't show any difference with depression versus non-depressed, but if you happen to be depressed, the degree of your depression is going to dictate your hospitalization impact on acute care. So the bottom line for the slide is that depression can impact acute care admission rates, and particularly in terms of the rehospitalization rates, which from a hospital's point of view, they get dinged. They don't get reimbursed if somebody shows up back at the hospital within 30 days. And there's been talk about extending that by Medicare by 90 days. So you can only imagine, if we're getting these high numbers of 18% readmission rates. Which, by the way, during COVID pandemic at Sanford Health, where I work, the readmission rate for all causes, not just for COVID, was around 20%. So it's a high number, and that's what we try to strive for in the outpatient setting, is to find ways to prevent that readmission rate, because the more times they end up in the hospital, the more likely they're going to be exposed to iatrogenic or unsafe situations that can cause further injury and death. So that's the whole rationale about trying to address recidivism. Next slide, please. So key points is that the determinants of acute care usage are different between middle age and older adults. Like I said, middle age, the more depressed you are, the more likely you're going to have more acute care usage. But in the older adults, that's not so true. And that both the age and comorbidities and hospitalization history are predictive of older adult acute care use. And so overall, depression is associated with a higher disability and falls rate, as I emphasized in that previous slide. So it's an important issue. Next slide, please. So some of the ideas for a clinical practice change, particularly in the post-hospitalized patients. So these are patients that a lot of times that I'll see, after they're been discharged from the hospital, they come to the geriatric clinic. And so they're advocating screening these individuals with the PHQ-9 as opposed to the PHQ-2, which is only 2 questions. The PHQ-9 is 9 questions. Also, for another consideration is to refer the hospitalized patients that screen positive for either fall risk or actually for depressive symptoms to send them to the fall prevention clinic. Right? There's different reasons why people send them to the fall prevention clinic, which we operate in at Sanford Fargo. It's one of the few. Well, I think it's the only one in the state that has a multidisciplinary fall clinic. Fall prevention clinic. But again, each healthcare system should have something similar to this if they're really practicing evidence-based medicine. So again, if you have a history of fall, fear of falling, or on medications that can cause falls, either through depression or just having depressive symptoms, those are all good reasons to refer to a fall clinic. Okay, next slide, please. So the epidemiology, this just shows that basically that minor depression, a variety of studies show that there's a wide range, so up to 1 in 2 might have minor depressive symptoms, but generally it boils down to about 1 in 10, maybe a little bit more than that. And in those people with minor depressive symptoms, they still use healthcare services a lot more. And what we'll see is that they have a lot of somatization. They'll talk about, oh, doctor, I have pain. And, they start waving their hands all over, right? And so that's part of that, what we call the somatization, a symptomatology of depression. But the issue is that they become more sedentary, they're less involved, less social interactions. They tend to have poor health outcomes and ultimately have an accelerated pathway to their end of life. And then conversely, the major depressive disorders, those are the really, people that you're going to start considering electroconvulsive therapy. They're really very vegetative. And that can constitute, again, in these studies, up to 1 out of 10 individuals. So you're talking about between major depressive disorders and minor depressive disorders, around 1 out of 4 patients, right? If you add those 2 percentages, the upper end of those percentages, you're talking about 1 in 4 people have some sort of symptomatology of depression. And of course, the setting makes a big difference. In the nursing homes, we did a study for not so much depression. We did just a quick evaluation of the percent of residents in a long-term care facility who we were asked some questions on loneliness and social isolation, and 68% of them indicated that they had some type of social isolation. And likewise with the hospitalized older adult, you can only imagine that those with COVID who have been, visitor restricted, as to how that might further, change. And then now that they're finding all these brain changes that are occurring post-COVID, you can imagine even for those that have recovered, whether they have brain fog or not, as to whether they might have depressive symptoms that we need to address. Next slide, please. So late life depression, I want to talk about the atypical manifestations. So I always check the what we call the graph chart, and we look at weight over the course of the last several months and trying to identify unintentional weight loss. Fatigue is a descriptor that older adults will use both in terms of if they're frail, but also if they're depressed. And of course, medication side effects, they just don't have enough energy. I mentioned about the somatic symptomatology, the reference to pain, paresthesias, and different kinds of, the sensations that just don't seem to, something's just not right. And again, it's not specific. It's not like I've got tennis elbow, and it's like, I'm playing tennis, although for me, it's pickleball. I just bought it. What I found. Oh goodness, Siri's talking to me. I just bought a set of pickleball rackets, so I'll let you know next time how that works out. But again, overuse injuries are different than these broad, diffuse somatic symptomatology. And of course, with our introduction of our case report here earlier, bereavement is a very constant, bereavement due to family member loss. Probably one of the worst things for people is to have their adult children precede them in death. And that's just really, really very difficult. And of course, loss of a spouse or other siblings or family members. Next slide, please. So I want to talk a little bit about the 3 stages of bereavement. I put down this lone tree as a picture here. It just kind of reminds me of this whole question of bereavement, the tree standing alone and with the waning sunlight here. And the first part of bereavement is numbness. That usually just not there, just kind of vegging and that lasts for weeks. And then it morphs into a depression, which can occur. We say about 3 months. At least that's the way I've been taught. And I don't know if that's exactly true, because quite honestly, memories of somebody that's close to you never go away. The sadness never goes away. It's always going to be there. It's just a matter of how much it influences your functionality. So I think that's the key thing. And that's where we talk about recovery, that the person is getting back to some semblance of a routine. And so that's considered, an improvement. Okay, next slide, please. So it turns out there's no gender differences in the onset or the display of depressive symptoms. Problems both getting and staying to sleep occur. There may be crying spells. And it was kind of interesting. When I was back in Chicago, I got a phone call from a news reporter from the Chicago Tribune. And he says, "Oh, I hear you're a geriatric doctor." And I go, "Yes, yeah, I'm head of the division here." And he goes, "Well, I'm just wondering, as a late middle-aged reporter, is it normal for older men to cry a lot?" And I said, "Why?" And he says, "Well, because I've been crying a lot." And I said, "Oh, so you're asking for some personal advice?" I said, "I can't give personal advice over the phone." But I said, if you find yourself crying, if I knew of somebody that was crying an awful lot, late middle age, I would be worried about some sort of depression that's going on, either potential loss of a job or, family situation or something like that. And then he turns around and he says, "Well, there was another geriatrician who from University of Chicago who says it's completely normal to be crying for old men." And I said, "Well, all right, that's, you got your range of opinions here." So, but getting back to the bereavement issue is that, people stop eating or undereat. So again, the anorexia, there may be a sense of anxiety and nervousness. And memory concentrated, they may be saying, "Oh, I'm forgetting the thing," like, "Where did I put my keys? Where did I put my keys?" Things of that ilk. Next slide, please. So again, the depressed symptoms for bereavement with the depressive symptoms, you can see the percent that decline over 1 month, so 40%, which is interesting because, 60% of people may not have these retained symptoms. And then it goes down to 15%. And then finally, you're going to see that after 2 years, there's going to be still a significant number of people that are still having problems post, grieving. Next slide, please. So the persistent depression occurs in a young old. So these would be 65 to 74-ish type individuals. If the grief lasts, I said 3 months, I still use 3 months clinically. So when I teach my geriatric fellows, I say, 3 months is kind of my cutoff for, worrying about it. But again, it's the degree of loss of functionality. I mean, if they're in a very deep vegetative system, state of mind, then there is likely to need to be more aggressive intervention. Next slide, please. So some of the communication tips here. So reminiscence therapy is always helpful. You have the patient tell their story of loss. What does it mean? You reflect with them about positive memories that they may have had about the individual. And then also to identify how things are different. You'll find things like my spouse always paid the bills and now I've got to pay them and I don't know where everything is. And so that not only creates depressed mood, it creates anxiety because I don't know what I'm, what I'm doing. And then this is an important question about, well, who's around to help you? Are there any family members? And if there are family members around, are they actually helping? I've had a few patients where the family members are around and they've been actually more of a, I don't want to say a nuisance than an assistance. And then lastly, that point of loss of resources such as driving, so you'll have a spouse who never drove or was, reluctant to drive. And so that they don't have somebody to get them around and they may be reluctant to use Uber or, whatever. So taxi cab. Okay, next slide, please. So the complicated grief, again, occurs in I use 10% as a round off, but it's in a significant number of patients, and they have some strange thoughts, so it's maladaptive. Their behavior gets a little strange, and they're very emotional. So complicated grief really, and I don't know if people that have a little quirkiness are predisposed to this or not. And I think the type of people I'm talking to. They're very eccentric, type individuals. But these individuals, like I say, will do things that are not typical of what their usual routine is. Next slide. So to just compare the two in terms of complicated grief and depression, there is some psychiatric delineation of that. So the complicated grief you can see there is this yearning. I wish for better days. There's sorrowfulness. I'm just feeling sorry about this whole situation. They also have these preoccupation of thoughts about the deceased person. They may talk about having conversations with them in heaven, as an example, and they just again have problems accepting the fact that the person has passed away. By comparison, depression is, instead of this yearning, I wish things were better, it's just like a flat out down mood. They have no sense of pleasure. That anhedonia is an example of just there's nothing gives them joy in life. Seeing the grandchildren, why bother? That kind of stuff. Sense of worthlessness. I don't know what good I am. And so there's that component. And then most importantly is the loss of function. So these people are just, kind of in a vegetative state. They just don't get, they're stuck in a chair. A lot of times self-care is neglected. And so that's, again, degrees of difference between complicated grief and depression. Next slide, please. So this is just a study that you can see at the bottom there that was done in, or at least published in 2016. And what was done for complicated grief is that they had several sets of sessions. There were 16 sessions in total. And what they did is they did a history. They had a monitoring of their symptoms. They provided some education about how normal the process was for grief. And then they went into additional sessions that engaged in past memories using pictorial essays, looking at pictures and describing them. And then finally having what we call an imaginal, or well, it's not a pretend, but it's a conversation with the deceased person. And so that's, it's a structured conversation, going back and forth with somebody as if you were talking to them in real life. Next slide. So you can see that this trial had almost 400 people. It was tried at different locations. And it was a fairly young population, right? So you're talking about 53 years old. And a lot of them, a third of them had some sort of violent death that was associated with it. And you can see that the placebo, so where they did very little, in terms of any intervention, versus the prescription for grief, those 16 sessions, really did not have a huge impact on that. And so it also, one of the points here is that the adding a medication, such as what we talked about before with an antidepressant, did not really impact the outcome. So there's something refractory about a certain percentage of these individuals in dealing with complicated grief. So it's a tough nut to crack is the bottom line on this one. Next slide, please. All right, so we're going to move to geriatric syndromes of late life depression. And we can recognize this because the older adults may be preoccupied with somatic symptoms. And they always don't say, I just feel depressed, right? They have more symptoms. They're not moving as well. They're not getting up in the morning as well. And the other point here is that among those who do not acknowledge sustained sadness, this lack of pleasure in life, anhedonia, for at least 2 weeks is important for the diagnosis of major depressive disorder, right? So these are the people saying, there's nothing to live for kind of thing. Okay, next slide, please. So the diagnosis of depression in chronically physically ill older adults is complicated because you have an overlap with other what we call chronic disease depressive symptoms. So the mood disorder due to a general medical condition should be used for patients with depression that appears to be as a result of a specific medical conditions like heart failure. Okay, if somebody has stage 4 New York heart, stage 4 systolic heart failure, and if they have a depressed mood, somatization, fatigue, all of that could really be explained in association with that general medical condition, of heart failure. So that's, again, it may be splitting hairs, but this is, sort of the diagnostic pathway that we go through in trying to figure this out. The implication being, as we saw with complicated grief, those young, old, and late middle-aged people are very, very refractory towards intervention. They haven't yet met the definition of true depression, but they still are refractory to cognitive therapy. Next slide, please. Yeah, so this gets at the screening. So the PHQ-9 is preferred for people who have known depressive symptoms, right? So if somebody comes in and says, I just have, I'm depressed, I'm in a low mood, you go straight to the PHQ-9 as opposed to the PHQ-2. Although the PHQ-2 is used in screening, right? So that third point there is that it's a screening tool, and it's a good one. You'll pick up on depressive symptoms pretty good with that PHQ-2. The other point is, the last point there is that serial administration of the PHQ-9 helps with understanding how well your interventions are, whether you're using cognitive behavioral therapy or whether you're prescribing a medication. You can use serial, responses to the PHQ-9 to see if you're making headway or not with your patient. Next slide, please. So the PHQ-9 has a score range here that you can see. So if you're scoring 1 through 4, no need to worry. If you are scoring between 5 and 9, that's considered a moderate depressive symptoms. And generally, that's where you want to reevaluate and consider cognitive behavioral therapy. But you can also give an antidepressant at that point as a trial. And then, of course, the scores that are greater than 10 can represent a major depressive disorder. And that's where you go directly to the antidepressant. In some cases, if it's profound vegetative symptoms, you may advocate for electroconvulsive or electromagnetic therapy, where they run the magnet over and try and reset the brain electricity. Next slide, please. The Geriatric Depression Scale has been a well-tested screening tool. It's got 15 items. They're just yes or no format, so it's pretty quick. The problem is it doesn't really account for things like sleep issues. It does not document whether there's any suicidal ideation like the PHQ-9. And it's not used very much for evaluating your treatment. So again, it gets back to that PHQ-2 and the PHQ-9 screening tool, which I think just about everybody's migrated to these days, at least in the ambulatory care setting. Okay, yeah, sorry, you can go back to bipolar disorders. So just to talk about the concept of bipolar, depression with or without mania. So an important point is that if somebody has a history of bipolar disorder, it doesn't go away as you get older. Okay, so there's a little bit of a myth about that. So if you've been diagnosed earlier, you still got it. And the episodes may be, as you get older, a little bit longer, and so it gets a little bit more progressive in a sense. And there may be more angriness, if you will, and hostility and irritability. So if you get somebody that's just kind of real cranky old men, that's something to think about in terms of whether it's a bipolar disorder or not. They're angry at everything. Next slide, please. So this just gives an age distribution so you can see, particularly in the orange graph there, that the brand new age onset in a middle-aged to late middle-aged individual does occur, right? So most of the cases occur around, just after high school, if you will, sometimes earlier. And then there's another group that after more towards, post-marriage, kind of that age group, college, and then again, late middle life there. So it just kind of gives you the sequence. Next slide. So for bipolar disorder, there are the diagnostic related groups here that they call the type 1 or type 2. And they're just distinguished by whether you have this low activity, this hypomania, right? So type 2 would be a major depressive disorder without the mania part, right? So they just are always depressed, but they have this real listlessness. I mean, they're just really vegetative. Okay, next slide, please. So the manic episodes may present with confusional states and disorientation, and that's always an important consideration, because what else do we think about? These manic episodes, we think of delirium, right? And so again, this is important to try to dissect, and you always think about delirium first because there are reversible causes of delirium. And these manic episodes oftentimes will be associated with grandiosity and contentious claims of certainty. This, we know this, and it reminds me of politics, quite honestly. Everybody knows the answer, right? So that's all that inflated self-esteem because everybody knows the answer. Makes me wonder sometimes. And then the other point here is the presence of psychosis, and so. That's, the kind of the dreamy state, like I'm seeing things, I'm hearing things. There's always going to be sleep disturbances and aggressiveness, again, which may be confused with either dementing illnesses or depression or delirium. Next slide, please. So this so-called late onset mania is often linked to some kind of medical disorder, typically either a stroke or a dementing illness, Lewy body, dementia, or interestingly, an overactive thyroid. And medications can also create this late onset mania. They may be a trigger. And I just cite steroids as being one possibility. Usually it's high dose steroids. And again, the steroids can also be associated with acute confusional states or delirium. The other point here is excessive use of alcohol and tobacco or nicotine products that can induce a late onset mania. And the other point here is to inquire about a history of hypomania episodes. So a lot of times these mania or these bipolar episodes go under-recognized because people don't ask, were there any periods of your life where you just kind of were out of it for a long period of time? Next slide, please. So unfortunately, alcohol disorders increase with age, and so too these bipolar disorders here. And you can see the green line there showing, the onset of these bipolar disorders over time. And I think we just have to recognize there's not. I don't know if there's a take-home message from this particular slide other than to say that the onset of bipolar can occur later in life. Next slide, please. So the bipolar type 2, as we mentioned earlier, it's got recurrent depressive episodes with these periods of listlessness. They're just parked doing nothing, they're vegetating. They may be, there's association with past episodes of hypomania that, again, the family and friends may not have, or even the patient really recognized. They just, weren't themselves for quite a while. And they may not attribute particularly depression to that, to those moments, but they pulled out of something, right? So they're off work for a while, just had a bad time at work, and, was it because of the bad work or was it because they were, depressed that led to bad work? It's kind of that chicken and egg phenomenon. Okay, next slide, please. Just to summarize, with bipolar, it's a lifelong illness, and people very rarely recover in totality. And the mania often leads to hospitalization. Unfortunately, the incidence of mania is not huge, although I have to tell you that interestingly, if you look at the statistics for the Veterans Administration hospitalization, the highest percentage of, or the most common diagnosis for admission to the hospitals are psychiatric disorders. And the next one happens to be heart failure. So it's just kind of an interesting concern. And one of the other things that a lot of these diagnoses, either schizophrenia, for example, or for bipolar disorders, they're often discovered in the military, right? Because they don't get expressed until somebody turns 18, 19 years old. And then all of a sudden, with either because of the stress of the military or whatever, that their symptoms become full blossom. Next slide, please. So this is a big one in terms of psychotic depression, because these are the people that have these false beliefs, these delusions, and very low mood. And a lot of these delusions are plausible. Like I had one guy that was talking about being pursued by the IRS. Somebody was going to get his money, and it was just this one particular, and he was focused on one IRS agent, right? But it's like there's many of them. It's not just one guy that's hounding you. And so that was an example, of a delusion. But it sounded pretty good. I mean, I've really felt sympathy for the guy. But again, it was because of his psychotic depression. There's also the consideration of these irrational beliefs that you need to consider. And these people at the final point there, these patients often jump around from specialists looking for answers. So if you find out, that's one of the questions I always ask is, have you seen anybody else for these problems, right? I've got pain all over, no doctor can figure it out. I go, oh, no doctor. Okay, what doctors have you seen? I've seen everybody. I've been to Mayo. I've been to da. And that's like, and you go like, okay, let's do a little deeper dive into this issue here. Okay, next slide, please. So I want to turn towards treatment. And the good news is that easily half of the patients with major depressive disorders will respond to the initial treatment. And then it goes from there that additional treatments will initiate recovery. The bottom line is that the vast majority, around 70 up to 75% of older adults that are properly treated with antidepressants and or use of cognitive behavioral therapy, CBT, will respond. So it's a very treatable illness. And that's why it's important with all these, with the falls and the morbidities that are related and the disability, our interventions are good if we can pick up on it early. So the current, I just want to finish that last part there. The current approach to mood disorders is to really be aggressively treated as soon as it's discovered. So the time zone then is about 6 months after symptom remission before you consider withdrawing therapy. But generally people are on maintenance therapy to prevent recurrence lifelong. Next slide. So in the first 4 weeks, you're going to get an idea of who's going to respond. And so there's this whole controversy about the type of antidepressant that you use. Typically, what my understanding is that if you use something like Lexapro or Celexa, you're going to see the impact within a week to 10 days. If you use something like sertraline or Zoloft, it may take a while for the titration levels to get there because you can't put older adults on a maximum dose or optimal dose right from the get-go, as opposed to something like Celexa, which you basically give the near optimum dose, right from the get-go if it's going to work. The other comment here, the second point about a visitor phone call within the first 10 days to make sure that the individual is compliant is important, right? Because people say, oh, I forgot. I mean, they do that with their blood pressure medicines. Oh, I forgot to take my blood pressure medicine. Or I had a guy forgot to take his Coumadin. Guess what? He had blood clots all over his body. I mean, it was like, didn't anybody tell you needed to be on this anticoagulant, medication for life? And he says, yeah, I just forgot to take it, kind of thing. So those lapses are very, very common. I mean, this guy I was talking to was a highly educated lawyer. I mean, they just, go into this, zone of either willful forgetfulness is what I call it, or they just truly just, forgot. Maybe it's like they didn't refill the medications and I'll just wait a few days until I, get the medicine back. But they can be really consequential. And the reason I'm emphasizing this medication adherence is that typically older adults who do not take their antidepressants on a regular basis often become refractory, and you have to resort to an entirely new medication. So I'll get to this question about the Seroquel here in a minute. Okay, yeah, so there we go. So these are the options. Just suffice it to say that the best choices are the top, the SSRIs. The SNRIs are they're activating, and they tend to cause more problems for the older adult. They're not preferred in the older population. TCAs, the nortriptylines of the world, have, sometimes you may recognize it as amitriptyline, which is considered a no-no in geriatric prescribing. Those tend to be older and they're effective, but not preferred compared to the SSRIs on the top there. Next slide, please. So here's the dosing, just as a disclaimer. You need to check the physician desk reference or others, if there's any prescription considerations here. But you can see the range, for the The first two SSRIs, which are kind of preferred in depressive symptoms associated with memory disorders. The key problem is that you have to worry about the EKG and make sure you don't have the prolongation of the what we call the QRX or QTC interval, the QT interval, which can be associated with malignant arrhythmias. And again, emphasizing the low sodium that can be induced by any of these medications. Next slide, please. Duloxetine is a favorite for a lot of reasons. It's used for pain syndromes, paresthesias, and it's a good medication. It's long acting, but it's you got to be careful with it, right? So you start at a low dose. You can see that people that have a strong alcohol history, it may be an issue because the medication is processed by the liver. The other medication there called venlafaxine, not my favorite. That's one of those SNRIs. And again, just all of those additional medications are in that class of SNRIs. So the NRI represents the norepinephrine, and that's not good for older people. Okay, next slide. Yeah, and then just low dose nortriptyline. Here I tend to go with the 10 milligrams. Do not use amitriptyline, or if you see somebody on amitriptyline and they're over the age of 65, get them referred to somebody who can prescribe nortriptyline. And then you'll see a lot of people on mirtazapine or trazodone because of the alleged positive side effects of appetite improvement and sleep induction, neither of which have been proven in randomized controlled clinical trials. But the myth of these medications persist, and even clinically, we say they're a little bit more sedating. So if somebody's got problems getting to sleep at night, maybe we'll give them low dose mirtazapine. And I just want to point out that once you go beyond 30 milligrams of mirtazapine, you're not getting the sedative effects anymore. Next slide. Oh, St. John's wort. So the bottom line on this is that it's bioequivalent to the SSRIs, the antidepressants, and in Germany, 75% of depressive medications are St. John's wort and not SSRIs. And one of the points I made, I can't recall the study, but basically, if you go to iHerb, to order these St. John's wort, if you get the alcohol extracted version of St. John's wort, and it's made in Germany, that's preferred to the solubilized stuff that you put in tea. So just as a word to the wise there. And this is helpful for people that don't want to take a pill. You say, well, maybe would you take an herb? And it's equivalent. So that's the good news. Next slide, please. So this is the, yeah.
Just a heads up that we still have quite a few slides to go through and we're almost there.
Yeah, good. Yeah. Okay. So I think maybe we can just finish with the using the, this is a good slide to actually transition. So remember we used the PHQ-9 for screening, but we can also use it to decide what to do with our medications. Either add a medication or maintain it. So this is just a little cheat sheet that you can use to help you help guide you in your clinical intervention there.